We work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
Doing so ultimately builds
a healthier, safer world for everyone.
We are the Kirby Institute.
Good morning, and thank you for joining us for the 10th annual Brett Tindall Memorial Lecture, which this morning will be presented by the Honourable Jillian Skinner. And she will be presenting a seminar on cross-sector partnership in responding to HIV. I would like to begin by acknowledging the Darwal people, who are the traditional custodians of the land from which I join you today. And I acknowledge the owner of the traditional lands from which we all gather at this seminar today, and pay my respects to elders past and present. I extend that respect to all Aboriginal and Torres Strait Islander people who join us today, and acknowledge that the lands were never ceded. Some housekeeping issues to start off with. The format of this seminar will start off with a presentation from Jillian, and that will be followed by a panel discussion and then audience Q&A. In terms of the audience Q&A, you can access this by typing your questions using the icon with the question mark in the center of it. That will appear in the Q&A section, and you can upvote any of those questions by clicking on them. We will try to get to as many of those questions as is possible. So I'd like to start by just some words about Brett Tindall, who this memorial lecture is named after. Brett was an inspiring colleague and a dear friend of the Kirby. He was born in 1961. He completed his first degree at the Cumberland College of Health Sciences, and then he spent 4 years as an undergraduate medical student at the University of Newcastle. However, he never completed his primary medical degree. Instead, he turned his attention to the AIDS epidemic that was sweeping Australia in the 1980s. When the Kirby was first founded, it was known as the National Centre of HIV Epidemiology and Clinical Research, or NCHECR. Brett was appointed as a research assistant by our inaugural director, the late Professor David Cooper. Brett was deeply involved in the Kirby in those early years. He rapidly became a senior project scientist and was also, for a time, the manager of the centre. When David was first trying to work out the appropriate response to the ravages of HIV infection, Brett was key in initiating some of the very first research responses. He was a great enabler, allowing research projects to be initiated and flourish, even in the context of a frightening, ill-understood epidemic. We all now have far greater insight into the difficulties associated with that sort of enterprise after our own experiences during the last 18 months. Our colleague, Associate Professor Garrett Prestage, knew Brett well and worked alongside him in those early days. He said of his approach, Brett helped clinicians understand how best to work with the community, to get services operating and to start the research response that was so needed. That approach of working in partnership with the community helped put Australia way ahead of anything else that was happening across the globe. Brett was one of the cornerstones of this partnership approach, which is, I hope, is still the basis by which we work today at the Kirby. This approach is a tribute to his insight, his motivations, and of the virtue of the way he naturally worked with people. Brett was passionately involved with scientific and community programs at both a national and international level that were developed in response to the HIV/AIDS epidemic. Notably, he was a committee member of the AIDS Council of New South Wales, or ACON. Through those contributions and his research contributions, he caught the attention of WHO. In particular, from 1988 onwards, Dr. Jonathan Mann, the then director of the Global Program of AIDS, frequently called on Brett to attend WHO meetings. In the early 90s, Brett was also a consultant to governments of the Western Pacific region, assisting them in their HIV surveillance programs and their policy responses. It was through his involvement with WHO that he met our patron, the Honourable Michael Kirby. They met at the Third International Conference on AIDS in Washington, DC in 1987. And they continued to cross paths through Michael's involvement with the WHO Global Commission on AIDS. When Brett learnt of his HIV status, he'd already commenced work in this field. His diagnosis just instilled a greater passion to make sure that he found that finding solutions to HIV/AIDS would become his life's work. Brett's research focused on the process of seroconversion, the body's initial responses to HIV, and how the infection should be treated. He continued to be involved in developing strategies and programs in response to the HIV epidemic at a national and international level, and he published prolifically with the likes of David Cooper, Ron Penny, and Basil Donovan. He was awarded an MSc here at UNSW in 1993 for his thesis, Factors Associated with the Human Immunodeficiency Virus Infection and the Development of Acquired Immunodeficiency Syndrome. Brett passed away in 1994, aged just 33. What an immense impact he made in such a short time. His legacy lives on not only through his work, but through the indelible impact he made as a friend of the Kirby, a friend to many of us here at the Kirby, and his approach to research and engagement. This annual lecture is our way of commemorating Brett and all that he achieved in his short life. It is so that his memory and what that signifies to our institute is never lost. Few of you will remember Brett Tindall personally. I, in fact, never met Brett because I started in 1993 in the lab, and he was already unwell at that stage. And so I never had the opportunity of interacting with him, but certainly his reputation at that time around the Centre for Immunology and CFI was unparalleled and was a model of how to do good translational research. Few of you will remember Brett, although many people here at the Kirby will have heard his name, and many of you will have read the plaque on the wall in our seminar room, which is dedicated to the Badger, which is how he was affectionately known to his friends. The inaugural Brett Tindall Memorial Lecture took place in 2012, and it has been presented by a host of prominent scientists, medical and health professionals. Today, for the 10th Memorial Lecture, we host one of Australia's leading leaders in the setting of setting the ambitious roadmap towards the elimination of HIV transmission, the Honourable Jillian Skinner. I will state that Jillian has gone above and beyond what is required of her and is joining us today from her hospital bed, and so is experiencing the health system that she bolstered and helped establish firsthand. And thank you, Jillian, for going to such lengths. Most of you will be familiar with Jillian. She is arguably Australia's most experienced politician in the field of health, having spent 14 years as New South Wales Shadow Health Minister and 6 years as New South Wales Minister for Health and Medical Research. Jillian implemented transformative policies and programs in a number of areas, among the most prominent being the control of HIV infection. As Minister, her leadership was essential in establishing 2 separate New South Wales government HIV strategies, both of which promulgated the ambitious goal of the virtual elimination of HIV by 2020. She officially opened the Kirby Institute when it was relocated to the Wallaceworth building at the University of New South Wales in 2012. Among her many achievements as the Minister for Health in New South Wales was her successful advocacy and support for funding EPIC New South Wales, a population-based PrEP implementation study which led to the dramatic reductions of rates of HIV infection in New South Wales and to the broad access to PrEP that we have in Australia today. This study has had impacts far beyond either New South Wales or Australia. Moreover, the policy that she led and implemented on HIV elimination embodies the strength of political will that is essential for addressing complex public health issues such as HIV. Jillian has made enormous contributions to the health and well-being of people in this state and well beyond, particularly to those that are marginalised. She continues to serve in numerous health initiatives, including as chair of the Australian Healthcare and Hospitals Association, director of the board of the Children's Cancer Institute Australia, member of Cancer Australia Advisory Council, member of the CSIRO Health and Biosecurity Advisory Group, and member of the Violet Strategic Advisory Committee. Jillian is known for her dedication to meeting community needs through consultation and government commitment informed by health and medical research, particularly for her support of innovative treatments arising from new understandings of disease and best models of care. The impact of her dedication and vision around health policy has been far-reaching and has improved the health of many thousands of people within New South Wales and beyond. We're extremely fortunate to have Jillian to join us today and to share her wealth of experience. Over to you, Jillian.
Thank you very much indeed, Tony. And can I also begin by acknowledging the traditional custodians of the land and to pay my respect to elders past and present. I also want to thank you, Tony, for that very warm introduction and to let people know I'm not in hospital for any hideous disease, but because I fell over and broke my leg, and I am now in John Hunter Hospital up in Newcastle being treated very, very well by all the staff here who have bent over backwards to try and show me, get me to this stage where I can address you. And I want to really start off by with a quote from myself. Back on June the 1st, 2016, I was asked a question without notice in the New South Wales Parliament. And I'd always said to everyone, please don't bring anything up about HIV or anything like that in Parliament because you polarise people. So when Alex Greenwich, the member for Sydney, who is a strong supporter of everything we've done in this space, asked me a question without notice, I was really little afraid of the reaction from some of my perhaps more conservative colleagues. And I ended my, what he did was ask me what the government was doing, and I won't go into all of that because I'll talk about it later, but I ended it by saying, as Minister for Health, I believe there will be many achievements that I can be proud of, that if I could have achieved the goal of ending HIV or eliminating the transmission of HIV effectively by the year 2020, that would be my greatest achievement. That's not the exact quote, but that's roughly what I said. And I meant it, and I still do, which is why I'm extremely pleased to be here today. And I'm really going to talk about what motivated me to get involved with in this space, what drove the passion towards developing the first of the most recent HIV/AIDS policy statements, how we were going to achieve that, results so far, and then more too from here. So I want to go with about the history of working in partnerships, because really that's what this whole theme is about. You know, everybody involved in this world of HIV/AIDS knows that one of the reasons why New South Wales and Australia has done so well in this space comparative to other parts of the world is because of our partnerships. It's always been an issue that's been approached from a bipartisan point of view, and with many participants, the community, governments, and so on. And I have a history myself of working in partnerships, no matter what work I've done. Immediately before being elected to Parliament, I was Director of the Office of Youth Affairs. And one of the things that I had to do was develop a youth health policy. I was invited to do that, even though I was a bureaucrat. I was invited to do that by the Minister for Health through the proper bureaucratic channels. My immediate response was, no, I know nothing about health. And the answer was, yes, but you know the population. Yes, young people, I did. You are good at facilitating, getting people to talk together. I didn't know what they meant until I sat down with a group of people, mostly from then Department of Health, who were going to be engaged. And I was shocked to find in those first meetings that they were sitting almost with their backs to each other. They were sitting side on, at the very least. And mostly I discovered it was because they were afraid that this outsider, this upstart, was going to come in and say, your money is not needed for the work you're doing. We're going to take it away and do something entirely different. Well, of course, that was not how it was going to happen, and it was not how it did happen. But it took nearly a year to develop that policy. And after about 3 or 4 meetings, I knew we were on the right track because people had turned their chairs, they were facing each other, and they were working out how they could work together to get a better outcome from the population we were talking about, young people. Keeping in mind that at the time, this was in the 60s, there was a lot of emphasis on youth unemployment, homelessness, mental health issues. And so some of the people that I was working with in health were covering those areas. There were people from the mental health area, from HIV, AIDS Bureau, from drug and alcohol, and so on. And I was very pleased in the end that we developed a youth health policy that in fact, was noticed at the United Nations. So that was an example of how I've always found working in partnerships is how you get the best achievement. And I say my being able to be here today really is partly because I have had the partnership of everybody in this hospital to help me get here, from the nurse who helped me have a shower this morning to sitting me up in bed, etc. They've been absolutely wonderful. So I want to now talk about really how that very first New South Wales HIV Strategy 2012-2015, which we called a new era, and that's time to switch to the next slide. Thank you. That's the cover of the document, and really it was about changing the paradigm. You know, beyond this first 2012 to 2015, maybe not a whole lot was achieved, but what importantly happened was when people started talking about it, we had the whole thesis was based on scientific evidence, and it was based on the fact that I was persuaded by scientists, researchers, and people that I trusted that we could work towards the elimination of HIV by bringing forward early testing and rapid testing, and then basing the results of those tests, if you were proven to be positive, on going straight to treatment. because until that point, you might recall, you had to have a certain viral load before you were eligible for treatment. So no wonder people were not getting tested early on. They were fearful of being found positive, but still not being able to get any treatments and dealing with all the stigma and legal issues that entailed at the time. So the idea was switch to early rapid testing and frequent, easily accessible, to then early treatment in the scientific evidence that once you were on the retroviral, the treatments, you became less infectious, you became uninfectious. And so it was based on testing, treatment, and prevention. And the important thing, there were many more things, but that was the major paradigm in that first iteration. And I just want to turn now to partnerships and why that was more important. Let's go to the next slide. I think the next slide shows you, and you can get all of this off Health website if you want, if you don't. This is the old one. This is back what we did back then. But it talks about the various people, participants that were involved in, these are the targets we will. And it was a whole range of people that were going to do things to work towards this HIV reduction in transmission of HIV. Then if we go to the next slide, and it tells you something about the partnerships, the importance of partnerships and the various people that were going to be engaged in this project. Partnerships in terms of HIV, as has been noted by Tony and others, has always been part of our success. And to me, it was illustrated by that opening of the new Kirby building, where we had Neil Blewett, Peter Boehm, Michael Kirby, David Cooper. We had many, many people, bipartisan, across the political spectrum, who'd been involved in HIV from day one. And I can tell you, in those 14 years when I was the Shadow Minister for Health, being mindful that there had been some negative views expressed by some people in the world. I had said to ACON, with whom I had a very, very warm relationship, please let us work behind the scenes. I will make sure your viewpoint is understood and taken on board by the coalition, but let's do it behind the scenes so we don't have that out in the public domain noise going on. And so that's why I was really thrilled to be at the opening of the Kirby with all those people there. So as I said then, and I've said since, that policy that we introduced was based on the good science. It was based on collaboration of all aspects of the scientific community, but also others, partnerships in critical roles of not only scientific, but social, legal, etc., educational, environmental, etc. And there's still much to be done, but at least I think we've made a start in relation to that. Then I was persuaded by this evidence, and I knew that it could be achieved. I should also talk to you about my own experience in my own electorate. I represented the electorate of North Shore, which really covers the lower North Shore from sort of Waverton Wolseley past Kirribilli, North Sydney, round to Mossman. Most people think that's a terribly conservative electorate, but the reality is it is in many respects, but it's also a very progressive electorate, and I regard myself as a progressive liberal rather than a conservative. And in fact, it had the second largest gay community of all electorates in New South Wales, first being Sydney, second being North Shore. And so I had a fair amount to do with people in this space as the Member of Parliament. I knew people who were infected. I knew people who had died. I worked very closely with organisations which I loved, like North AIDS, which unfortunately ceased to exist in about 2005, but which was helping the kind of people that were HIV positive in my world, which were an older professional group, many people who had spent all of their savings because they didn't think they were going to survive, and then needed counselling, financial counselling, etc. So I had a first-hand experience there. But then when I was developing this policy, I had absolutely amazing support from my own personal staff and personal friends. Chris Public, who will be known to nearly all of you, has been a friend of mine forever and ever. And all through my opposition years was my wise counsel whenever I developed policies or anything to do with HIV/AIDS. And the one thing Chris always drummed into me, and if you're listening, Chris, I will never forget it, is even if you think you've eliminated HIV, you can never forget it, because it's got to always be on the agenda. We've always got to promote prevention, safe sex, safe needle injecting practices, etc. And so Chris was really fundamental in me putting together this policy. And the other person was my Chief of Staff, Andrew Kirk, who was my Chief of Staff nearly all the years that I was the Minister and had been a friend for many years. And many of you will know, and I've got his permission to remind people, that he has been HIV positive since the year 20, I think is 1984, I believe it is. I know Andrew's listening. So when Andrew told me the science was right, I could with confidence endorse this policy, then I believed him. And I believe it still, and I think that's been proven to be the case. The others that had a profound influence in those early days were others on my staff, people like James Bolster and others, but people like Bill Botel, Bill Whitaker, and then from ACON, Nick Parkhill, Karen Price, who will be joining us a little later, and from the ministry, Kerry Chant, who really did the most amazing team, and I'll talk a bit more about them later. So those are the people, that's why, and the people, the players. The others are organisations, for example. So ACON, I've mentioned some people there, Marcor is another. Organisations like Positive Life New South Wales, the Needle and the STI program unit, the Society for HIV Medicine, the New South Wales Users and AIDS Association, Aboriginal Health and Medical Research Council, sex workers, and so on. Now, can I tell you, it's very funny. We released this policy in 2012, and I knew I had to persuade the Commonwealth to come on board with that early testing and early treatment. And that was going to be a real challenge. But the planets aligned, and the AIDS Congress was being held in Melbourne the next year. So David Davis, who was the Victorian Minister at the time, inviting me to participate, because he got the Congress before I was even elected, became the Minister. He invited New South Wales to have a little session beforehand in New South Wales, and then to have a workshop in Melbourne. So in the session beforehand, it was attended by the Commonwealth and nearly all the main players. And I said to them, look, we need to get a goal out of the AIDS Congress. And how about we have this goal that we've now released of virtually eliminating the transmission of HIV by 2020. Here's what we need to do. Minister, who I shall not name, Commonwealth, will you agree to join up and give us the early treatments? Yes, Jillian, he said. Other states, will you come on board? So as a consequence, it was endorsed by the Commonwealth and all ministers, and became the Australian, basically Australian policy at the AIDS Congress in Victoria. Also at that AIDS Congress, they did we did a little workshop, and there was a panel which comprised all of these people I've just talked about, the sex workers, needle exchange people, ACON, and many others. And they were very complimentary about me. And I said to them at one point, well, if I ever get into trouble in Parliament because this conservative, middle-aged, I regarded myself as middle-aged, woman was leading the push in this regard, I want you all to be in the gallery so I can point to all my supporters up there, representing all of this broad cross-section of the community. Anyway, that didn't have to happen, so we moved on. The other important part of this I mentioned in that policy was the intention to move towards the use of PrEP. So let's move over now to the next slide, please, because we're switching over to the 2015 strategy they're on. And, you know, at the end of 2012-15, the decline in the diagnosis had been modest. It had stabilised, but it had been modest. Fortunately, we kept mothers and babies transmission in hand, sex workers in hand, needle exchange in hand, through the kind of things that we used. But PrEP was still very early days, and it was the missing piece of the puzzle. And yet evidence had shown that it was taken daily to prevent HIV transmission. It was extremely effective. So this is where we joined up with the Kirby Institute, and I wish to particularly acknowledge the late Professor David Cooper, who was such a lead in this space. And even though I didn't know him either, Tony, clearly Brett Tindall was an extraordinary young man who made a major contribution to the way HIV was handled and indeed to the way the Kirby was established. But to Andrew Grulich, who really was the lead in PrEP, and particularly the EPIC New South Wales, the first of the global studies, I believe, which looked at the impact of PrEP on the community which was addressed, which in fact was the men who had sex with men. Can I then turn to the next slide? So really, the EPIC New South Wales really was the first large-scale implementation trial of its kind in the world. And this really helped us sort of start to meet the goals of the United Nations political statement on eliminating HIV. And I think we've gone from strength to strength in this ever since. And so that PrEP really now has had a major impact. In the early days, it was just a trial to start off with a limited number of people, but it's moved on. Early days, we had very generous support of Gilead, the pharmaceutical company, because it was a clinical trial, and it meant that we could really move on with this program. So let's move to the next slide now. The responsiveness of the health system was critical to the success of EPIC. So as it points out here, in the early days, most of what we were doing in this space was really located in the sort of specialist sexual health units and hospitals that dealt with HIV. And thank God for the sisters at St. Vincent's, is all I can say in those early days. They are simply gorgeous. Even though I'm not a Roman Catholic, they adopted me, and I'm very grateful for that. But one of the other things that we were doing is in rolling out greater mobilisation of our strategy to local health districts, to district nurses and local GPs and pharmacies. So, and that made it a lot more accessible for people. And I know from talking to people who've accessed some of these facilities, services, it's made a huge difference. So at the peak of enrolment, as it shows here, the EPIC New South Wales provided PrEP to nearly 9,500 people at high risk of infection. This is men who had sex with men. And around 60% of the participants were born here, 40% overseas. So it shows that there was a gap there that still needs to be addressed, I believe. We've continued to ensure that that people continue to access PrEP with the listing of PrEP on the PBS in 2018. That's made a huge difference. We also had a policy in 2015 going to that election of making a subsidy, providing further New South Wales subsidies for S100 drugs, which included those for in the HIV area. So, as I've said, sexual health clinics have involved, they've increased treatment, prevention, a whole lot of things there. And I should say that Dr. Julian Gold, who also is I hope he won't mind me saying a friend, I led a delegation along with Kerry Chant to China in 2014, I think it was. And one of the things we did whilst there was visit the WHO Centre for HIV AIDS, and Jillian helped set that up as well. So let's move on to the next slide. So it's really, this is talking about integrating what we were doing into the mainstream. So it goes in, it's now part of the performance reporting arrangements through the local health districts. And can I just say that the local health districts really, if I'm talking about some of my proudest achievements, that would be another one. And it really became, I always knew it was important, because until we really built up strength of districts, we were relying upon a very centralised health system. These districts now they each have their own public health capacity, etc. And can I tell you, one of the reasons why in early days of tracing COVID, we did so well in New South Wales compared to other states was because we had local public health people who could do the testing and tracing locally, and it made a huge difference. So here we are now with, they're much more involved in tracking, tracing, and implementing a lot of the HIV strategy that we have rolled out. And we report on the progress through quarterly reports. They're available through the New South Wales Health website. And we now have the world leading target for a 90% reduction in the rate of HIV prevention, which I'm very, very proud of. Over to the next slide, please. So we have, as I said, a multifaceted approach to the elimination of HIV, harnessing approaches right across the system. We have the service agreements at the local health districts. We have regular data reporting. We have research and collaboration. And can I say the work that's been done through the Kirby Institute is fundamental to all of this. They've worked very closely with New South Wales Health through Kerry Chance, people there. And I should also give a shout out to people in the ministry, to not only Kerry, but to others who have been so involved in this space. With early days with me, Joe Holden, Meredith Claremont, Christine Selvey, and Dr. Chris Bourne, who's part of the panel later on. Can I tell you a story? On Saturday, 2 weeks ago, when I was first admitted to hospital, the 2nd of October, probably more than that now, when I realised I wasn't going to have access to my files, I sent a text to Kerry saying, no, you're so busy, but any chance you could help me answer a couple of questions about, where to from here? And her response was immediate. And she replied and said, you and Andrew, she meant Andrew Kirk, were so fundamental in this area, happy to provide. And she provided these slides, most of these PowerPoint slides by the next 2 days later. So thank you, Kerry. Thank you to all of the people that were involved in doing all of that work. So next slide, please. And it's the last one I have, I think. No, next one after that. I think I've covered that off. Let's move to the last one. Yeah, future challenges. This is really where we've done, there've been 2016, we produced another strategy, and then the last one, which was released by the current Health Minister, Brett Hazard, it goes 21 to 2015, 25. It shows you some of the results that have been achieved. And all of these are built on that very first one that we introduced in 2012. But we're heading for the target of a 90% reduction in the rate of preventable HIV infection. But it also needs to, we need to still address some of the issues, such as some of the communities are not as well addressed or accessed as others. So, for example, I think people living outside Sydney might have more difficulty. So it's about expanding access to PrEP as well as condoms and other things. People who might still have a stigma, and one of the other issues are stigma, the legal issues around HIV infection. I wish I could deal with that with a click of my fingers, but there's still things that need to be addressed. And we need to maintain our focus on early testing and treatment as soon after diagnosis as possible. And can I say, my everlasting memory of all of this work is running down the street with people like Nick Parkhill and Karen Price and others after opening their pop-up testing centres around the Mardi Gras or their new head office in Elizabeth Street. And the joy of people working together and those amazing campaigns that ACON led, and award-winning campaigns to educate people about what we were doing. So that's really all I'm going to say at this stage. But it really is a lesson in everyone working together, everyone committed to helping people, helping each other, and never giving up. And I think we've achieved enormous things. And I'm ever so pleased and very excited that what's been achieved, particularly through the Kirby and the EPIC and PrEP, has been noted internationally, written up in the Lancet, and I think well deserved. So congratulations to everybody involved. And thank you very much for listening to me from my hospital bed.
Jillian, thank you very much for that terrific address and for really pointing out some of the essential components of that underpin what's been an extremely effective and transformative response in New South Wales to this infection. I want to now move to the panel, and to start that, I'd just like to introduce each of the members of the panel who have generously agreed to participate. So I'll start with Dr. Chris Bourne. So Chris is a medical advisor at the Centre for Population Health within New South Wales Health. He's a senior staff specialist at the Sydney Sexual Health Centre and a conjoint associate professor in the sexual health program here at the Kirby. He has worked in sexual health and health medicine for more than 30 years in urban, rural and remote Australian settings, and has provided consultancies in Southeast Asia and written sexual health care guidelines and trained healthcare workers on how to apply them in clinical practice. The second member of the panel is Professor Grulich, Andrew Grulich, who is head of our Institute's HIV Epidemiology and Prevention program. He has worked in HIV research for more than 30 years and is still got some black hair there and has been with us since 1995. He is an internationally renowned authority in the transmission and prevention of HIV and STIs and the epidemiological relationship between immune deficiency, infection and cancer. Karen Price has over 20 years experience in the health sector with roles in government, non-government and university sectors. Karen has an extensive experience in policy development, advocacy, innovative service design and program management. Karen is currently the Deputy CEO for ACON, Australia's largest community-based HIV and LGBTQ health organisation, and has been with that organisation since 2013. And if you ever need a dose of enthusiasm injected into a committee or a debate, just ask Karen to turn up. And finally, I want to introduce Tim Walk. Tim has over 6 years experience in delivering HIV, sexual health and LGBTQ health peer education programs in New South Wales. As manager, community partnerships, peer education and population programs at ACON, Tim works across a diverse range of health promotion projects aimed at ending HIV for all and improving health equity. Tim is also co-chair of the Called Gay Men's Action Group and has led the development of ACON's first multicultural engagement plan. So I'd like to open the discussion with the panel with a fairly broad and far-reaching question that I might regret. And I'd like Jillian to start, given that she's got such experience in this area. And really, when setting strategies, such as the HIV strategies that you set and have been set more recently, what's the right balance between the aspirational goals and the vision and the practicalities of implementing that? And so I might start with Jillian and then go to Karen to comment on that.
Yeah, thank you, Tony, and it's a very good question. I always think you've got to understand what your vision is first. You have to know what it is you're trying to achieve. That's your vision. I'm doing some work in this space at the moment in relation to children's cancer. And then, you know, you sort of work towards, you work, it's a step process. You work with the people that are going to be involved in setting the strategy or implementing it. You work out what you're understanding what the science is, then you develop the strategy, but it's also got to be implementable. It's no use having a fabulous strategy that's going to look great, glossy piece of paper and sit on a bookshelf. It's got to be able to be implemented. It's got to be endorsed by multiple participants who you want to engage in it. And it's got to be exciting. I started my working life as we called ourselves reporters, not journalists in those days, because we reported, not journalised. And I'm a writer. That's my background. I hate long, turgid documents. So I like punchy, short, sharp, get to the point, tell the story about where, when, what, how, and motivate people. So it's about getting the vision right, then getting the strategy right. It has to be based on achievable science, achievable activities based on science, and then an implementation plan, and importantly, a monitoring plan with outcomes that can be measured and reported, so that there is then a commitment to it going forward, which is why I think we've now got, I think we're up to the 4th HIV plan, Tony, and now we've got all this great reporting with outcome of PrEP. I hope that answered your question.
That was extremely systematic. I was taking notes for the future. Karen, would you like to comment from a community organisation's perspective on developing these strategies and getting that balance right?
Yeah, absolutely. Thank you, Tony, and thank you, Jillian, for your address and your commitment to being here, given your situation currently. So thank you very much. Look, one of the things I reflect upon, you know, that 2012 strategy document was called A New Era. And what I love about this whole modern history of HIV in Australia and New South Wales in particular is that it really did turn a chapter. The advent of new science, new technology, new research outcomes really did give us a new platform, but bold targets and aspirational targets. You do need to bring the community with you, and you do need to actually, as Jillian said, I think really wisely, chart your success or measure your performance, measure how you're going towards those targets and communicate. And I think that's one of the things that you can be bold as long as you continually back in the science and you tell people how it's going to work, the pathway to get there, and then you measure and record what's going on. So there's a degree of transparency and report back. But the other thing it takes is persistence and staying the course. And one of the things I think Jillian and her office and Andrew and others really did well, Kerry, the late David Cooper, bless him, really, we have now a consistent direction, a forward direction that is well leading in HIV, because we didn't give up after 3 years and we didn't give up after 6 years. And it will take what it takes, but we need to stay the course. And I think the recent results really show that. One quick anecdote before I hand over. It was a bit of a bracing, I would say, Jillian, with all due respect. Visiting Andrew and yourself in the office there for the first 12 months of this new era was actually quite, you had to sort of take a deep breath and step boldly into the office, because, there was a real sense of a shake-up. We're going to do things differently. We're going to take it on, and we're going to shake this thing up. And that was from chief executives of local health districts right through all the HIV partners, clinicians, local health districts, the whole lot. There was a very clear message that static HIV levels was no longer success. That's not progress. We need this thing to go down. And what does it take to get there? Well, you all need to do more differently, get together, work it out. So there was this real problem-solving, driven boldness that wasn't just written on a policy document. It was actualized in funding agreements, in the way that the system worked, and everyone got the very clear message that get on board, because the train is pulling out, and if you're not on it, you'll be left behind. And that bold action gives people confidence. It's frightening for a minute because change is, but it's also giving people confidence. And, ACON put a very bright fluorescent pink giant condom on the obelisk on Elizabeth Street. And that you wouldn't get away with that without the real clear knowledge that your minister's going to back you if you're going to end up on the front page of the Daily Telegraph for all the wrong reasons. And that's the confidence it gave to make real bold choices, to get out on the front foot, take our community with us. And that persistent direction, I think, has really changed the game in New South Wales. So bold targets can only be backed up with the partnership, but you've got to stay the course, and you've got to have, you can be brave if you know you've got the support of the people behind you. And I think that's really the legacy of your early leadership in that space, Jillian. Having served 14 years as a shadow health minister, I know you had your guns ready to go as soon as you walked into that office, and you didn't miss, which was awesome. And thank you.
Andrew, I might pass to you and ask you, there was that real shake-up of the system. I remember it well. We were, I think a lot of people in Australia were very happy with the fact that we had stable levels of HIV infection. It wasn't increasing like it was elsewhere in the world. And so there was a lot of backslapping going on the basis of that. So this was very much a big shake-up. That with that sort of change in strategy, how does that free you up from an academic point of view to think about what's possible in terms of the sorts of research that you do?
Yeah, thanks, Tony. I think it's easy for us in 2021 just to forget how much things were changing around this time when the minister started in this role. Because, in 2010 and 2011, we had the primary results presented on treatment as prevention, which, as a scientist, I was very much shocked that treatment would be 100% protected. I really wasn't expecting that, and when it hit, it was extraordinary. And at almost the same time, the first PrEP results in gay and bisexual men, which, although not as conclusive when the data were teased out, were also very suggestive that this would be extremely effective in people who were adherent. And so, I think it was those scientific results which really underpinned this ability to turn everything around and not to do anything by halves, to say, hey, everything has changed. Everything has changed. But as a scientist, I was pretty concerned about the treatment as prevention advice at the time, because the data at the time were all in heterosexuals, and we knew that there was HIV in semen, even in people with undetectable viral loads. And so that was a real impetus for us to be able to do the opposite track study here in Australia, and others to do similar studies in Europe, which proved later that it was as effective in gay and bisexual men as in heterosexuals. But the PrEP data, I think that the innovation in policy in that field led by the Minister and led by Kerry Champ, was absolutely extraordinary, because a few years later, in 2014-15, we had the evidence that PrEP worked in small-scale studies, and yet we had an unregistered, a drug which was not registered for PrEP in Australia. It was very expensive and didn't look a very feasible thing to do. And we as researchers, because of this close partnership and the real interconnectivity between all the players, they're always in each other's ears and picking up phones, and which we take for granted, but it's very rare. But we were able to talk to the policymakers who we knew would understand the evidence, because a lot of them were trained scientists, and to say, hey, this should work. Look at the modelling. If we can roll it out quickly, we should be able to do that. We don't know how to make this happen because nobody's paying for this drug, and it's an expensive study. And very quickly, through amazing policy innovation, the department was able to identify a way that we could import drug to do the study. And we were able to be the first in the world to show that when you implement it at scale, you saw substantial reductions in the population. And I should say, they were the up connections, if you like, but the out there connections with community, cannot overstate the degree to which that community education and demand creation was critical to this impact. Other parts of the world were still arguing, having terrible, useless conversations about Truvada halls. But here it was just simple messaging. PrEP prevents HIV. And so it was really that interconnectedness of all of us and the clinicians as well, which enabled this sort of research to be done.
Chris, if I could ask you, as someone that has sat or sits on both sides of the fence, both in terms of determining the policy, but then also having to see the patients and implement the policy in the sexual health clinics, taking EPIC as an example, perhaps what the impact of that was on places like the sexual health clinics and the patients. I think it was, a lot of the grunt that actually underpinned the success of EPIC was, at the coalface at those clinics. And so, how do you actually implement this extraordinary change and this challenge?
Thanks, Anthony, and thank you, Jillian, for your lovely summary. It was beautiful, actually, to come across in the way that you have the sense of from the front line right through to the policy and sort of community level and how that all comes together. And I have to say, it's been a privilege having been involved in many earlier strategies, and this sort of shake up and energy that was created by the approach that you enabled. And I have to say, the elegance of those really sharp-ended strategies and what are we going to do, how are we going to do it, who's going to do it, and how we're going to monitor it and by when, I think has really energized the sector overall, but also gives people that fabulous visibility about, so what are we doing and what's my part in it? You can really see it quite quickly. And I agree, I'm someone who abhors those long-winded strategies that just have words and sit on shelves. You want it to be a usable thing. And I think we've learned a lot from that time in lots of other sectors that we work to. But to your question, Tony, and it was like a steam train, let me tell you, going through sexual health services, because over many years there'd been a lot of reprioritizing and refocusing on priority populations more broadly, which clearly included gay men, particularly because of the burden of STIs more broadly, and particularly HIV. For many years, and in fact, that was the initiative for actually sexual health services being funded and set up across all of New South Wales in the early days of HIV, and we're really, reaping the rewards of that legacy, to be honest, and we're able to mobilise that very quickly. And Kerry Chant would come to the directors' meeting in a way that, I hadn't seen before, and it was quite extraordinary to see her involvement and wanting to understand what can I do to unblock any challenges you might be having at the front line. And I want to shout out to the sexual health services who, were really having to not only previously they learned how to triage all of the priority populations, and suddenly they were having to triage again and mobilize around gay men to get them on the threat through EPIC. And everyone stood up and did that incredibly well without, dismissing other priority populations at the same time. And so we're able to adapt to the trial or the study implementation model that was developed, which also allowed lots of nurses to be skilled up to be taking assessments, which they were doing previously, but also being now able to be involved in delivering medication to gay men for this new way of approaching care in a prevention sense. And it was, because we had the strategy, everyone was able to see and be able to be articulated in their part in that the whole program of work. So why are we doing this? So the admin staff, the counsellors, the nurses and doctors could all see, why are we doing this? Why are we seeing lots of gay men suddenly? And it's because we've got this energy and it's being supported from the top. And what that also enabled, and Kirby and the Minister were able to do this, is it also gave leverage at the chief executive level within LHDs to help reorient the services and to fund some of those changes that needed to be made to make those change quickly, while supporting, their continuing care of other sexually transmitted infections. And you might remember some very vigorous conversations early on in those strategies where the sexual health services, who knew that they were going to be a key part of this rollout, were not going to let go of the other STIs. There was a big push right at the beginning that you will do HIV, and that's what this is about. You will only do HIV. And they were very powerful and ultimately listened to. And you see, actually, we have a legacy now that we actually have learned a lot about that and contributed a lot to not only the health and well-being around STIs for gay men and other people, but also research input and having done some very elegant studies around this amazing EPIC study to help answer a lot of the questions and myths that developed very quickly about that PrEP was going to, make more STIs, but in fact, we were able to tease that out. And in fact, more testing meant more identification of infections at the same time. And so we could actually counter some of the ideas that were coming from other places in the world about, and as Andrew mentioned early on, that it sort of in a way got rid of the Truvada whore sort of narrative by saying, well, actually it's about detection of infection, and that's a good thing. The sooner you do that, the more healthy you will be, not only for HIV but also for other STIs. And so I think it's lovely that we've been able to use that setting to drive that change. And also to then elegantly transition to the PBS listing to support access to general practice, which has been something we've been struggling with more generally with HIV care to try and get more care. But it's also meant that the sensitization of gay men and their lives and their concerns has been able to be diffused through general practice more broadly, which has been a challenge for many years, and people have had some bad experiences. And I think this is another example of how that conversation, where any GP now can prescribe PrEP and gay men are rocking up in droves in places that GPs wouldn't have expected to be asked for those questions anymore. And in a way, they're sort of being forced to learn about the care of gay men in particular, but not only gay men, but around HIV. And so it's given us another angle at which to continue conversations in the primary care space. So yeah, big shout out to the services in sexual health for their participation in EPIC particularly, but also continuing to treat people early. That was the other thing I guess we haven't mentioned yet, is about not just about the PrEP, but was the earlier initiation of treatment for people with HIV. And there was, that was an interesting conversation because people were still concerned that there was this group of, while a lot of very well informed gay men were happy to start treatment almost at the time of diagnosis, there are other groups of people which were becoming more the dominant new diagnosis, people from overseas or non-Australian born people who needed more time to initiate treatment. And so there was that tension between immediate treatment and like just giving people time to get used to the diagnosis. So there was that interesting feedback, and the partnerships helped that conversation be a respectful one and to integrate into, service targets and strategy targets, for example.
So Tim, I learned earlier this morning that you were working on the communications around EPIC as well, and so I guess some reflections on the challenges and what went well and the lessons from that in the back rooms.
Definitely. So just before I begin, I just want to acknowledge that I live on Wongal land of the Eora Nation. I'd also be remiss as a young gay man not to acknowledge all the people living with HIV that came before us, because it's without them we wouldn't have had this progress today. I think that's important for me as a young gay man to acknowledge. I do think this conversation is really interesting in the sense that everyone here is talking about how that partnership model was quite easy to push through, because as someone on the front line, I didn't know any of this was happening, which means it was working. So we on the kind of community health promotion level didn't know about all of this. Our role was really just to actually translate this kind of new simplified message that PrEP prevents HIV and turn that into community language. And it was actually, I think, a little bit more complicated on the front, kind of in the front line. So we actually had to take that and talk about, well, what does this mean if you're going to hook up with someone? What does this mean if you're in a relationship? And even though we missed, I think, a lot of the kind of discussion around Truvada whores, we did see some of that conversation come up when we looked at culturally and linguistically diverse groups. And I think that was one of the challenges at the time, that we were putting out these campaign messages, but how they were being received was quite different depending on, say, your cultural background. And that was really important, because part of that actually meant that we went through the process of translating a number of PrEP posters, I think, into 5 different languages. And that was highly effective in actually getting people where language was a barrier or culture was a barrier onto PrEP. And I remember at this kind of start of the rollout of EPIC, this was a barrier that we were really facing. So it's definitely, my experience is different to everyone else here on the panel. I was not in those rooms at the time. I didn't know all of these conversations were happening, but the messaging was complex. And for the first time, we were saying to the gay community, actually, there's a new way for you to prevent HIV. And it took a little bit of time for people to get on board with that message. I know we had a lot of people who knew about this from overseas, but yeah, it took a little bit. I'd say it was a little bit more complex than necessarily what's been discussed so far at the community level.
Thanks for that. So perhaps looking forward and given the current strategy, where do people think the biggest gaps and challenges are? What do we need to do to get to that aspirational goal that Jillian so boldly put before us of elimination of this infection? And Tim, maybe I might go to you first to talk about the culturally and linguistically diverse populations.
Group. Yeah. So I think you opened with a question around strategy and how we ensure that strategy is achievable. I do think as we're moving forward with our response to the HIV epidemic, it's also looking at who is in the room when we're making those strategies. So I know back then with Jillian and everyone here, like by including community, we ensured that this strategy could be translated into on the ground projects like what I used to deliver. But as we're getting to the pointier end of HIV, I also think we need to make sure we have culturally and linguistically diverse people in those strategy meetings at those levels, having input. So we're just ensuring, like then, that's continuing forward.
Andrew, would you like to talk about how, as an academic, you might address some of those gaps?
Yeah, I will, Tony, and I'll just also briefly comment on the identification of those gaps. One of the great things about this working in partnership for such a long time as a researcher is that the NHMRC values and respects this in the form of these things called partnership grants. So we've been working in direct partnership with New South Wales and the community organisations and the clinical organisations to set up measuring systems so that we can identify these gaps. And we have a great snapshot of where we're up to in New South Wales at the moment. We know, for example, that in the inner city, we've had reductions already in the order of 70% of diagnoses in gay and bisexual men. We are doing fantastically well in the inner cities. And that becomes slightly less good as the further you get out away from central Sydney. So the suburbs, the regional and rural remote, we've had declines, but not nearly so great. So that's a big challenge, replicating our successes in the inner city out in those regions. Another area that's emerging as an issue, it's not as big an issue, but I want to name it, and that is young gay and bisexual men. We are getting slightly lower levels of PrEP uptake in young gay and bisexual men. Of course, don't have this long history of familiarity with HIV as a disease, even. HIV is something that impacts upon them. That is a real challenge. And as has been mentioned, overseas born, particularly the recently arrived overseas born gay men who are not yet hooked in with all our HIV prevention technologies. And talking technology, just before I hand back to you, Tony, we do have a great big challenge heading our way, and that is the second and third versions of PrEP. Within the next year or two, we will have long-acting injectable PrEP. And after that, within another couple of years, we'll have 6-monthly PrEP, and we will have yearly implantable PrEP. All of these things will be in addition to our current situation. They're all going to be costly compared to our current very, very cheap levels of types of PrEP. So we have challenges at all levels, but they're all implementation issues about what are likely to be very effective new types of PrEP, which will help us on our way to elimination. So as a researcher, I actually really look forward to these days. These next 5 years, it's going to be some great research questions and some great new work that we all need to do together.
So Andrew, I think those technologies are very interesting, but we still need to get into those hard to reach communities. And perhaps if I could ask Jillian for some advice, and then maybe Karen about how we build those partnerships and make them sustainable with these. You know, the epidemic is smaller, but it's also more diverse and less concentrated, and that has its own challenges. So how do we best address those challenges?
Thank you, Tony. And I've been looking at the Q&A that are listed down the bottom of our screens for the panel, and a number of people asking me how to do this, do things going forward, particularly in relation to comparing, excuse me, COVID with the HIV approach. Unfortunately, I'm not a minister anymore, so I can't answer all of those questions. But I think the reality is it's capturing the hearts and minds of people to make sure that there's a maintained interest in this as an issue, but also picking people who can be champions. So, for example, I'm not sure how it is right now, but there was always a difficulty of accessing a whole lot of things for people who lived outside of metropolitan cities, so into the country. And it's probably improved dramatically, but I still think there's likely to be an issue there. And that's where, you know, you'll find through the local health districts, there will be people that you've dealt with or that you can link in with who are as passionate as I am and all of you are about this topic, that can be your sort of introduction to ways to work with those communities. The same with CALD communities. Tim, I don't know if you've been working with the multicultural health team, but they are wonderful. I love them dearly, and I'm sure they are able to provide you some assistance. People like tap into, you know, the Chris Puklicks, the Bill Botels, the Bill Whitakers. They still have very strong and continued links into the community. And also, people often ask me when I do this kind of talk, How do we get into ministers? Look, keep in mind that ministers change all the time and there are backbenchers there who aspire to be ministers. So try and track down people in Parliament, doesn't matter what persuasion they are, who are showing an inkling of an interest in this sort of topic and nurturing a relationship with them, because they can be your champions going forward. That certainly worked. ACON did that with me when I was Shadow Minister. I think they might have approached me before I approached them. But it's certainly worth doing that as well. And the other thing, and you've touched on it, Tim, is understanding the cultural differences of people of non-English speaking backgrounds. It's not just a language difference. I know one of the other social policy areas that I was particularly interested in, keen on, was organ donation. And I know for the Chinese community, there was a real impediment to heart donation because they had a belief, a custom, that cultural belief that you could not, that the heart actually had to stop beating before you. So which meant that it was very difficult. Once we developed a way to transplant a heart that had stopped beating, it was then a matter of working with the community to ensure that they understood all of this. So it's a very deep cultural discussion. It's not easy, but it is achievable, and it's exciting when you get those champions that can help you achieve these things.
Things to add there, Karen?
Yeah, look, just probably 2 or 3 quick comments. Partnership is a word that is often referenced, but rarely operationalised to maximum potency. And I think that a real key to this moving forward is that we maintain the energy and connection and commitment that we share across community, clinicians, researchers, and politicians, and also public servants, policymakers, to really keep driving forward. So I think the potency of the partnership, we often talk about it, but it absolutely is one of, it's best practice, and it's better than the partnerships that exist across cross-sectoral partnerships in any other area of health that I've ever been involved in. You really do work. We really do walk the talk in this sector, and that needs to keep going if we're going to continue to realise those goals. The other thing, 2 or 3 things quickly, a problem-solving mentality is what we need, because rural and regional, scarcity of resource, cultural and linguistically diverse, all of the different aspects that we all need to continue to keep in mind are, depending on your worldview, either problems or they're opportunities yet to be realised. And we need that problem-solving mentality, not to have blocks or barriers. We need to work it around. And that, I think, typified the first strategy, the 2012 to 2015 strategy, was around workarounds. It absolutely typified what we did with EPIC. It was, there's a barrier here, how do we work around it? The implementation focus of that study set it apart. We were slightly terrified about whether we would get 3,700 men on PrEP in a very short space of time to get that implementation aspect right. And we nailed it, and we kept going. So that problem-solving mentality is crucial to our future focused efforts, I believe. Then there's 2 other things I'll say, and that is that we have a real opportunity that's been handed to us through the experience of COVID, where, for example, we're about to have self-testing kits available to everybody, individuals, workplaces, whatever. We've got still some regulatory barriers to break through when it comes to self-testing, when it comes to HIV, that we can't just go to the chemist and pick up a HIV testing kit. There's still some very careful, cautious kind of aspects to that, and I understand why, but ultimately we need to be moving more and more towards individuals having control of being able to take control more of their health in wherever setting they are. And Jillian mentioned stigma, and she wishes she could fix it with the click of a finger. One of the things we can do while stigma still persists is to actually allow people to do more of this testing, which we know we need to get higher testing rates. We've seen the absolute power of COVID testing being in the hundreds of thousands of people a day to work out what trends are going on and where things are at. we can only do that if I think we empower people to do that more often, as much as we can, for themselves. And I believe that would also help with remote and difficult to reach, geographically difficult to reach settings where you don't have a sexual health service on the corner, and GPs are, perhaps rare as well. So one last thing, and that is we have a really interesting opportunity / challenge / opportunity, because it is an opportunity, but it is a bit tricky at the moment, where we've got people coming out of lockdown, getting back on the horse, so to speak, and they've lost to a certain extent their sexual health routines. So we've got to kind of warm up this ground around what a PrEP program looks like. It's not just the pill. There's the whole thing that goes around getting tested regularly for HIV, well, for STIs, having that relationship with your doctor or your sexual health clinic or Dr. Bourne down the corner. These programs and the success of our overall HIV response relies on habits of people, behaviours, getting the people at most at risk to do the things we need them to do to benefit their health, does require constant reinforcement and re-engagement. So that's our challenge, I think. But COVID has offered us some very interesting and I think pertinent examples about how to keep moving in that direction.
Tim?
I just wanted to jump in on what Jillian Skinner said, because I feel like you really captured kind of what's so important with the work I do, which is that we need to tap into the cultural context when it comes to culturally and linguistically diverse people, and really understand that there is a different understanding and relationship with HIV. And that when we have our mainstream campaigns, which are really effective at reaching 90% of the population, as we're coming down to the pointier end, we need, I would argue, and I am in peer education, that we need more investment in peer education to have those one-on-one conversations, to actually provide the peer education that is informed by cultural context to change that understanding and to challenge stigma. Because I do think when we think about stigma, we've also got to understand that's overlaid with all other aspects of our identity, and that peer education is one of the most effective ways to challenge that and is needed.
Chris, if I could ask you, so delving into some of the questions from the chat and also the ones that came in prior to this, both Karen and Andrew have touched on technological advances that might help us with health messages and prevention in general. What do you think the role of telehealth is and the digital platforms that we have, and what have we learned from the last 18 months of implementing that in COVID?
Well, I think what we've learned is that patients love it and clinicians, like for any of these sort of clinical system changes, are sort of a slower adapters, because it's a change of, I guess, the culture of care and the interaction, and people feel removed from it, and there's a nervousness that there's things being missed without the sort of direct interaction. Most of the telehealth, I guess, around sexual health or PrEP and has been more telephone rather than like online with visuals. So, and I know there's the scale up of that coming soon, the visual part of it. And I think, well, that will help to reduce some of the hesitancy from the clinical services point of view. But what I think has been excellent about it is that, in fact, the electronic prescribing and people going to the local pharmacy to pick up medicine. So, in fact, there was almost no excuse why people needed to miss their medications or to not get the script on time, because, in fact, while a lot of the services closed down to, reduce the risk around COVID, there was certainly a heightened awareness that anyone with HIV or needing HIV prevention meds were clearly at the top of the list in terms of accessibility. So that in the mains kept going. And I think patients like it. I think there's going to be a natural tendency when we open the doors, so to speak, more freely with high vaccination rates, that we'll just default to how we worked before. But I think the smart way forward is really to say, well, what worked, what didn't, and what can we keep doing that was working? The clear winner, as you've said, Tony, is some of that telehealth stuff, and it's becoming embedded across the whole health system. And so that needs to happen, continue to happen. And obviously thrown into that mix is, of course, as Karen's mentioned, the sort of self-testing and the ordering of tests or getting tests under your own volition in different ways than you might have before, which isn't a specific clinical environment. And I guess we've led the way a bit under Jillian's leadership again around the dry blood spot project, for example, and that was sort of an initiative to look at some of the populations who are being under-tested, included obviously other strategies around hepatitis C to help with that accessibility part. And so that's an example of, in a way, online or remote medicine that people are being tested in outside of a come and sit next to me while I take your blood type approach. Or have a conversation directly. I guess added to that mix is, I guess, the online chat and communication, which is also scaled up more within the clinical space, where patient dialogue has gone from a voice, a more predominant form of communication to a more electronic and messaging and like email exchanges and sharing of information that way. We've got a way to go, I have to say. There's still some challenges, at least in the health system, in communicating with non-health, other health systems in terms of encryption and privacy issues and things like that, but that's sort of coming and they're all manageable, I think. So I think there's some exciting times and some good things to continue. Yeah.
Thank you. Jillian, if I can come back to to summarize some of the questions there, there's, how do we, so prevention is, as we know, is better than cure, but it's also not as sexy and harder to focus on. And one of the problems with being successful in prevention is you don't have the problem, so no one gets recognized for it. Have you any words of wisdom to answer Bill Botel and Peter Bone's plea about how we focus on prevention rather than therapeutics?
Yes, and I saw those comments from both Bill Botel and Peter Bone. And look, this was always something I tore my own hair out when I was a minister. I created an Office of Preventive Health, and I set up a ministerial advisory team and so on. But it was very, very difficult to give it the kind of resources that it needed. I think it really needs to be led from a national level. And it's something that I'll take on more thinking about it now, wearing my health and medical, my hat as chair of the Health Care and Hospitals Association, because and really one of the very interesting things, projects that we've undertaken in that body, and it grew from work that I'd done in New South Wales, was what's called value-based healthcare now. When I did it was integrated care. And it's really looking more at how you can give a multidisciplinary approach to addressing issues that prevent them accelerating to the point where they need tertiary or even clinical care at all. There was a very good conference in Perth earlier this year on this very topic. And it's very interesting having a look at some of the things that the workarounds that clinicians are doing, things like allied health. So physios are getting involved in work with people who might have been identified as needing joint replacement, for example, working up their fitness and so on. But that's still minor compared to what we really should be doing. So look, I acknowledge that this is a huge problem. We need a much bigger investment in preventive health, but I don't, for the state, you see, the state's responsibility, my responsibility as a Minister for Health, was primarily about running hospitals. So the capacity to do much outside of that was, I had to be inventive, to be perfectly honest. I used to walk around with a big folder, Mary Foley used to drive her mad. And the big folder said Minister's priorities in the biggest print I could find. And it had things like HIV, organ donation, nearly all the social policy issues which were not covered by the normal run-of-the-mill budget increase for hospitals. And it you know, in the scheme of things, I mean, the New South Wales health budget is over $25 billion. It's a third of the state budget. And it's nearly all eaten up, and it will be for a long time now, in trying to deal with surgery and other things that have been put off. So getting enough money to approach the health from a preventive point of view, I think really takes a national approach, and everybody should be really focusing on trying to make that case, I think.
So I think we should wrap up on that note before Zoom cuts us off. And I guess it's a demonstration that even the great Jillian Skinner doesn't have all the answers to everything. So thank you very much, Jillian, for that great address and all your input, and to all the panel discussants. I think it's been a very lively discussion. I hope the audience has learned a lot from those discussions. Thanks very much. Certainly it was a great tribute to Brett. Thank you, and we'll close there.